these here are the laminas, right? But this whole area here is the articular pillar. But the lamina is superimposed over the articular pillar, and then the spinous process, you only have one, there's no right or left, is right in there. So let's go from a vertebral body. So vertebral body, pedicle with transverse process overlying it, and in this case it has to be to the right. And then you've got the articular pillar, which attaches to the pedicle, of course. And then behind the articular pillar, but it looks like it's in front or in the middle of it, is the lamina and then the spinous. So remember, you're going from front to back with the vertebral body. If you're looking at a lateral, vertebral body, pedicle, articular pillar, lamina, then spinous, right? So that's on a lateral. So then just take it and rotate it 45 degrees, and nothing's changed. It's still body, pedicle, articular pillar, lamina, spinous. Remember, spinal lamina junctions in there too. But things start becoming superimposed. And so in this case, you've got the pedicle, the articular pillar, and then the lamina there. It's still behind the pedicle, but here it's just superimposed over the middle of it. Yeah.
Can you see the pedicle on the other side?
Question?
Can you see the pedicle on the other side?
Yeah. The pedicle on the other side,
the thing towards the front?
Are these circles here?
So that'd be
These are the
other side or the
pedicles
same side?
on the other side. Yeah, they look like circles. So all of these are the pedicles on the left side. These are the pedicles for bars on the right side. And it's always true, you shoot a right posterior oblique and a left posterior oblique. You don't mix up anterior and posterior obliques. You shoot right and left posterior or right and left anterior. Okay, so we're good with that. Did Joe not tell you about my packs? And I know we didn't really get into a demonstration here, but I did indicate that what you might want to do, these are not options to put together around my packs. It's just MYPACS. MYPACS. Go to the internet. It's free. Make up your own password, right? And then just go to search once you get in. Go to search, and then just go normal cervical spine, normal humerus, normal shoulder, and some of this stuff will come up, right? So if you want to do that, you're welcome to do that too. It's just called My Packs. And then remember your password, because there are like thousands of different cases. So when you start studying, and Dr. Thompson will utilize it during your classes with him, you'll go there, while you're in lab. And then, there's other places to go to, University of Michigan, University of Indiana, Washington State. They all have radiology departments because they all have medical facilities. So, you can get into their programs too. And oftentimes you don't have to have a password. But MyPax is there for you to use. It's very valuable. Okay, so all of this stuff we've talked about already. Flexion extension. The thing that you need to know here is that it's true that on flexion you get stair stepping one vertebra on the other, less and less as you get lower down in the cervical spine. And we said that it might be okay to have the vertebra going retro on extension, but we don't want to, between flexion and extension, have more than how many millimeters? Otherwise, you might have intersegmental instability or laxity. 3. Yeah, 3 or 4 millimeters, right? Good. So 3 or 4 millimeters. I say 4. You probably were taught in other classes 3, and that's fine. And also, too, remember, if you had a problem with the transverse ligament on flexion, the predental space would open up, wouldn't it? And then it would close down again on extension. If you were missing the transverse ligament, remember who's missing one?
Down syndrome.
People with trisomy 21 for sure. That's possible. People that are with a full chromosome complement or whatever, normal chromosome complement, may still have agenesis. It would probably be rare. But they could have rheumatoid arthritis or some inflammatory process that's destroyed it. Don't worry about this, you get that later. We didn't talk about this much, but you can see the articular pillars really well. You could do a bilateral, as we've done here, right and left, of particular pillar shots. Okay, so Chamberlain's line, remember, from there to there, right? Again, should not project more than 3 silly millimeters. This is the posterior aspect of the hard palate. This is the what?
Opistion.
Opistion. Okay, and the way we find that, we could follow our spinal laminar line up to the opistion, or where the inner and the outer table come together, that's the opistion, which is the what? Posterior aspect of the foramen magnum. So anything above that line, and here, now we're getting into the lines. I want you to make sure you know the significance. I'm not gonna have you draw the line, I mean, that's not practical, but I would like you to identify the line and give me the significance of the line. So here, the significance is softening of the skull base, right? And what's softening the skull base? Osteomalacia, hyperparathyroidism, fibrous dysplasia, Paget's disease. That's all in your notes. And then we need to throw in osteoporosis, even though that's not softening, but you can get little microfractures. Okay, so that's that. That's Chamberlain's line. McGregor's line, the only difference is the measure, and you're going to the most inferior aspect, and not to the opistion, but the most inferior aspect of the occiput, drawing a dot there and a dot there, and connecting the dots, and the significance is the same. So that's McGregor's. Predental space you know about already. George's line should be smooth and continuous. The two things that oftentimes disrupt George's line is the vertebrae either going forward or back, or it could be degenerative change off of the uncovertebral joints, or it could be a fracture, of course, you know, the posterior elements, and they become, you know, retropulsed, or they go back, right? Retroposition. So you're looking for the integrity, I guess, intersegmental relationship of one vertebrae to the other. There we go. Here we can see George's line is disrupted, obviously. Back here for C3, up here for C2, we got to go all the way back to there, and it's because there's a fracture. Posterior cervical and spinal laminar line, kind of serving a similar purpose. So both George's line and spinal laminar are good, especially with trauma. And here we can see that same fracture, which is a Henry's fracture. The fractured fragment, which is the lamina, the articular fossa, the spinous have gone retro. Sagittal canal dimension. I just want you to know that at C3 and below, that it should not measure less, not more, but less than 12 millimeters. You know, if you want, you can memorize all the minimums and maximums, but I don't recommend it. So just 12. Some people have said 13 millimeters, close enough, but 12. So this is how we determine it from the most anterior aspect of spinal laminar junction to the mid portion of the vertebral body. That would be the sagittal canal dimension. Gravity line, draw from the tip of the dens a line perpendicular to the floor or the bottom of the film. And this line should crop to the anterior 1/4 or 1/3, close enough, of C7 vertebral body. And if it's anterior to that, it's anterior weight bearing, posterior that, it's posterior weight bearing. The lordosis, this is called the atlas plane line, so a tip, middle of the anterior tubercle, tip, posterior tubercle, connect the dots, extend backward, go to the inferior endplate of C7, extend back, and then drop a perpendicular from the atlas plane line, go up with a perpendicular from this line, no name for this line, and then make sure that you know that it's a small angle that you measure. So there and there. We said that the lordosis isn't as important as the weight bearing, right? So that's more significant. Ruth Jackson's physiological lines of stress. In extension, they should be C4-5 where they intersect, and then C5-6 where they intersect with flexion. And that's where force is being directed, force vectors. So those might be areas. If it's not where it's supposed to be, then you look for degeneration. deterioration as the person ages. You know these already, retropharyngeal, 7, 21. Here, obviously, we don't have to measure. You can see that it's pretty extreme, right? We don't worry so much about less than, but we worry definitely about more than. And that indicates what? There could be an abscess there, or so some sort of an infectious process. Could be soft tissue swelling, and maybe there's fracture of the spine. Could be a space-occupying lesion of any type, you know, thyroid mass, whatever. Spina bifida, you know, not a problem. Again, cortical bone facing cortical bone, nice smooth parallelism between the two halves, and both halves are corticated. Here you can see spina bifida, or it's called spondyloschisis. Again, if the little crest or ridge of bone is missing, then we know it to be posterior conical, calcification of the posterior oblique suboccipital ligamental structures. What's going through that foramen? And what's the name of the foramen, by the way? Arcuate foramen, and it's vertebral artery. Right? So it's all about the size of the arcuate foramen. Os terminale, here's tomography. Bergman, it's also called. Hyperplastic transverse processes, they do not extend beyond, and normally we see these at C7, but you can have, here's T1. Remember, epitransverse and pericondylar, Jay looked it up for us. What difference does it make as long as you have one or the other? Right? The pericondylar, I think, comes down and articulates with the transverse. Epitransverse goes up from the transverse and articulates with the pericondylar, meaning beside the occipital condyle area. Here we can have, and we usually have smaller vertebrae from front to back, transverse processes that are hyperplastic, and they actually form an articulation with the transverse above. Calcification of the stylohyoid ligament, remember, we needed to distinguish that from vertebral artery calcification. This is probably one of the best shots to see calcification of the vertebral artery. You might could see it on your obliques going through the mid portion of the IVF. Here we can see the calcification. Not so hard. Nuchal bones. You need to differentiate those from maybe onto secondary growth centers that are displaced or fractures. Blocked vertebrae. Remember the criteria. Wasp waist, rudimentary or vestigial disc, IVF. Oftentimes they're small. This one looks large. And then you've got fusion with posterior elements, one spinal laminar line, and one continuous cortical margin for the two articular pillars. Close up of the same. This one is a little tricky. Looks like you've got more than you need. So I think you've got, in addition to blocked vertebrae, there might be a hemivertebrae in there. Right? Something doesn't look right here. This looks like a little triangle. So only half of the vertebra. Usually it's the lateral aspects of the core. Occipitalization, right? You do flexion extension, you wouldn't see those two separating out, right? They would be one. And here it's hard to get a good AP open mouth, right? And here are the lateral masses, and they're fused. Foramen magnum is here somewhere. They're fused to the occiput also. Very rare to have agenesis, but we see this more commonly. This is the one that you have to do flexion extension for. The little os is here. It looks like that can be the dots, right? And there's cartilage in between. Here's tomography showing it does look like a dot. And then the paraodontoid notches are here too. So with flexion, you can see that the occiput, C1 and the ossicle all go forward. And then on extension, everything goes back to where it should be. They also have spina bifida here. So not unusual. They've got one anomaly that might have another in the same locale, or it'll be in the lumbar spine. Agenesis or hypogenesis, posterior arch. There's cartilage there, just never ossified. And same thing here. This part did, but the lateral aspects didn't. Right? Cervical rib, C7. Right? If they're big, they can cause problems, obviously competition for space for brachial plexus and subclavian artery. Here we've got an oblique, shows the rib really well. There has to be an articulation, otherwise it's just hyperplasia of a transverse process. Thyroid cartilages, who knows why they calcify, they do. Here's a good example of them. Again, not vertebral artery. Here would be your vertebral artery. Okay, laryngeal constriction, when that overlies a bifid spinous process, could look like spina bifida. And here's the spina bifida. Mock effect is just a loose instrument you see there, right there. Two structures as they're superimposed. Here's the anterior arch adding density to the tip of the dens, posterior arch adding density to the base of the dens, and the in-between looks like a cleft. Teeth can do the same thing. Or this, in this case, this is non-union of the anterior arch, but teeth can do the same thing, as you can see there, there. Pseudosubluxation in that this is a child, so it's not unusual, or an infant, that the lateral mass go beyond the body of C2. We said that sometimes it's hard to see these facets because of their angulation, whereas typical vertebrae, C3 or below, you should be able to see them, provided there's no lateral bending, and if there is, then you start seeing two of them. Facet notching, here more commonly the anterior superior aspect of C3, but you can have them elsewhere. There's a little notch there, maybe here. A little notch there. Let's see, pull it. Here we have a little notch. Okay, I think the rest, and here's our laryngeal cartilages. The rest are just repetitious. The posterior conical, those are ones that I added. So just go through and make sure you know your normal variants. They're all